This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. Today's presentation is titled Keystone Pathogens of the Human Mouth, the Critical Need for Saliva Testing, and will be delivered by Dr. Tom Nabors. From 1970 until 2006, Tom managed a family dentistry practice with special interest in oral microbiology and immunology. He was the first dentist to use phase-contrast microscopy and DNA lab reports as a diagnostic and treatment model. He began teaching the value of DNA-PCR testing in 2003 to oral health professionals and continues teaching to this day. In 2008, Tom founded Oral DNA Labs, the first USA-approved clinical laboratory using saliva testing for oral infection, including periodontal pathogens, genetic variations, HPV-related oropharyngeal cancer, and systemic inflammation. He served as its chief oral systemic scientist and dental officer. It was the first US-based clinical laboratory for both dentists and physicians. Dr. Nabors has spent over 40 years researching and developing a clearer understanding between a medical-grade definition of periodontal infection and how these infections are directly related to chronic systemic diseases. He has many firsts to his credit, as well as several scientific awards and honors. He is a nationally recognized authority on the use of DNA-PCR as a critical component in both oral and general health and disease issues, and is why we're so excited to have him joining us again today. Attendance at today's event entitles you to apply to receive 1.5 hours of PACE-approved continuing education credit. Shortly following Tom's presentation, you will receive information on how to apply to receive your CE. To be eligible, you will need to successfully complete a brief quiz, as well as note the course number, which is NAB 072122. And now it is my distinct pleasure to welcome back to the Practice Perfection stage, Dr. Tom Nabors. Welcome, Tom.
Thank you so much, Dan, for that very kind introduction. And thank you, too, for the many years that you have spent in improving the lives of all of us that are in dentistry per se. And I want to thank everyone that is listening this evening for your time. I know you've spent a long day in the office, and I appreciate so much your effort to attend this discussion. It's a discussion that has intrigued me for many, many years. And it centers around the idea that we can improve our diagnosis of periodontal disease, and we can improve the way that we treat these very serious infections. So as you can see from the title, Keystone Pathogens of the Human Mouth, the second story here is the critical need for saliva testing. Briefly, as a background, as Dan mentioned, I've spent the majority of my 54 years in dentistry helping to figure out how we can use new technology to create a medical grade diagnosis and then drive not only our original goals for periodontal treatment, but also an endpoint goal that is quite different than what we have been taught. I've been privileged to invent, if you would, or to found a number of laboratories, and I have had also the privilege of viewing tens of thousands of case studies using DNA PCR type testing. And today, for full disclosure, I am the chief of the oral systemic medicine at Direct Diagnostics. I use the sort of opening slide here relative to each one of you that are in a dental practice to include all of us. Each one of you that are involved in, quote, dentistry really are involved in a medical practice. Each one of you in your own unique way are in fact healers. And that is the original definition of a physician. So I hope that each one of you considers very seriously the impact that you have, not only the oral health of the patients that you see, but also the potential systemic health that you can provide. I'm going to emphasize this relationship here, and that is the relationship between a very, very important dental hygienist. I use, of course, a female here because most of our dental hygiene colleagues are females. However, I do realize there are more and more young men that are entering this field, and that's a good thing as well. But the reason I want to emphasize our dental hygiene colleagues is that you have such an incredible area of responsibility relative to the overall health of your patient, and certainly relative to the systemic health of every person that you see. So the main points of our presentation this evening are to understand what are keystone pathogens. Another name for that would be called red complex pathogens, and they're critical links to both oral health and systemic health. And saliva testing itself, as we're all familiar with, of course, the periodontal probe. The periodontal probe is a way of classifying damage, but salivary testing gives us, for the first time, a gold standard for an original diagnosis. And as we look a little further, we need to understand how periodontal infections differ from patient to patient, and understand saving teeth is certainly an important goal. That's what we were trained to do, but there are new goals for our diagnosis and treatment. Perhaps the most important slide that I will present to you this evening is this one. It was published in Periodontology 2000, October 2017, and it was titled Quo Vadis, meaning in Latin, where are we going? So there are two areas that we're going relative to the world of periodontal disease, and that is one, curing periodontal disease, and number two, linking periodontal disease to systemic diseases. And as we look at this illustration, and as you look at the first circle, it says access patient's path and monitor outcomes and guide decisions. Now, if you take your eyes down to the lower right, I have a rectangle there. This rectangle is presented in this study to clearly show from studies of people that were in their 90s and even in their hundreds, compared to those individuals who were in their 50s, 60s, and 70s, that those that lived longer had less chronic systemic disease in their 60s and 70s and 80s. In fact, those that lived to be 100, by the time they were 60, only 5% had type 2 diabetes or cardiovascular disease or had suffered from a heart attack or stroke. Even by the age of 80, those who are on path A, meaning a very healthy path, had very few systemic chronic diseases. Only 20% of that very aged group actually suffered from a chronic disease. And yet those who were on path B, in other words, a rapid progression of systemic disease, by the time they were 60, 40% of those had a chronic disease. And by the time they were 80, 80% had a chronic disease. What we realized there is that any systemic chronic inflammatory disease reduces the time that you'll live here on Earth. And it also reduces the quality of life. So what this is saying for those of us that are diagnosing periodontal disease and treating periodontal disease is we have to have some way of accessing that path. When you see a patient, you have to have an image of, is this patient on a fast path of dying early, or are they on a slow path of dying early? Now, that's not your total responsibility, but later on we can help you understand that, and we can help you align with medical providers that can give you further insight. But that's a really, really interesting aspect when we see our patients. The second thing that we want to recognize here is our primary responsibility as dental hygienists and as dental team members, and that is to resolve periodontal inflammation and be able to monitor systemic inflammation. But those are two things that are somewhat aligned, very much aligned, but are somewhat different, because our responsibility is the first part, resolve periodontal inflammation. So how do we do that? Well, if we look to the left, we do our clinical examination. If we go over here, we can clearly see that. We do our 3D imaging, and look here, salivary testing or salivary diagnostics. So that's the way that we monitor periodontal inflammation, also the way that we monitor the quantitative local endpoints of therapy. So for the first time that I've seen in literature over the past 40 years, this is the first time that there has been a real scientific effort for us to see where we actually land in this world of systemic health. And the area that we're most responsible for is resolving periodontal inflammation through the use of salivary diagnostics. If we look on the other side, and our medical providers will actually do more of this than us, and that is we'll be able to monitor systemic inflammation and monitor systemic parameters that represent control of disease, such as diabetic control or cardiovascular heart, let's say blood pressure and so forth. And there are many other tests, of course, that can be run in blood and in urine. But this is a phenomenal look into the scientific view of where we are, those of us who are treating and diagnosing periodontal disease. So if the term Quo Vadis is where are we going, and now we define where we're going, how are we going to get there? Well, we have to get there through saliva testing. And the way that we put saliva testing in practice is simple to expel 1 milliliter of saliva into a tube, as this patient is doing, and that's capped off, and that is sent to a qualified clinical laboratory. The laboratory, over a period of just 24 to 48 hours, can assess what's in the saliva for the information that is directly related to your patient relative to periodontal disease in any stage and relative to systemics of diseases of chronic inflammation. This case that you see of this beautiful mouth there, I'm going to show you a little bit later, but I wanted to show someone that you might not test if you weren't testing those that might have risk. So what are we going to be testing for? Well, we're going to be looking for red complex bacteria. Another term for those are keystone pathogens. Why? Because these are high risk relative to alveolar bone loss and also relative to systemic inflammation. These lines, if you've never tested before, represent those most important pathogens that we'll be testing for, such as, and I'll just use the initials, AA, PG, TD, TF, and FN. For those that are testing, maybe using an older model test, you'll recognize those and you'll recognize the names. The lines represent not only detection, but also level based on these mathematical numbers here. So AA is discovered at a lower rate than PG, TD, TF, and FN. There's a significant amount of information that we can share with you at another time, but these are the high-risk pathogens relative to both oral health and also relative to systemic health. So in conclusion, really, of what we are trying to say about saliva testing, why do we really need it? Well, we need it for 2 or 3 reasons. One is that when we look at clinical trials relative to just doing scaling and root planing, in other words, that's all we're doing. We're moving biofilm and we're removing both subgingival and supragingival accumulation, and that's all we're doing. Clinical trial clearly showed, even as old as 2006, that roughly 67% of our patients are still infected after we do a very thorough job of scaling and root planing. That doesn't mean that you are a bad clinician. In other words, this was a controlled trial with trained periodontists doing the scaling and root planing. So it's not that they weren't doing a good job. It's just that these pathogens are scaling and root planing resistant because they don't necessarily live on the root surface. They tend to live more in the tissue. Another is a meta-analysis just this year in March of 2022 of 4,610 studies, and it validated this 2006 study by showing in these studies roughly 1/3 to 2/3 of every patient was still infected after just scaling and root planing. In other words, no other medication, home care being brushing and flossing, the typical model that we have all been trained with relative to treat these very serious diseases. So that should alarm us. It certainly would alarm me if I was in practice today. I actually noticed that though 40 years ago, and that's the reason I changed what I was doing, is there were too many patients that were coming back still infected. So why why are they still infected? And that is because these keystone pathogens, AA, PG, TF, TD, and FN, are resistant to the mechanical therapy that we have trained to use. Obviously, I'm not saying don't do that, But what I am saying is we need to do other things along with that. So these keystone pathogens also cause systemic inflammation and are independently linked to many chronic diseases. And lastly, the reason that we need to use saliva testing is we need to improve our treatment outcomes. So where are we today? I don't know. I'm assuming most of us have heard these phrases before. Our thinking as we come out of our school and as we come out of our training has traditionally been this: we can't cure periodontal disease, and once a perio patient, always a perio patient. Actually, that always bothered me, and it bothers me even more today because it's not true. So how did we get there? Well, I would suggest to you we got there because that's the way we've been trained, but also our organizations such as the ADA, AAP, and ADHA traditionally teaches that the only diagnostic instrument that we have is the periodontal probe. The periodontal probe was actually invented in 1936 by Dr. Williams and is used today as the only real diagnostic instrument. Of course, we do staging and grading and we do bleeding scores and all of that, but we ultimately classify disease based on the damage that has been done. So I oftentimes have created this little model here that I think is maybe his home, and that is, are we still lost as a profession in 1936? If we are, we need to really reconsider that, because the periodontal probe cannot determine what the infective agents are. So what kind of literature do we have that actually supports saliva testing? Well, here's one. It says basically what we're doing with the traditional model of probing, attachment loss, occlusal abnormalities, habit patterns, staging, grading, and so forth are inaccurate. And we know that to be true. As Dr. Schlotz would say, we end up undertreating serious disease, maybe overtreating early disease, or not treating at all because of the inaccuracy of that. Another thing that I would say relative to our treatment is that we tend to be trapped in yesterday's studies. And what do I mean by that? Well, when we look at the studies in 65 and the low studies relative to gingivitis, or just the accumulation of plaque on individuals just because they don't brush and floss, even then, in other words, what I'm saying is that's basically the model that we're using to treat periodontal disease. In other words, removing plaque, removing calculus, removing biofilm. But it's even stated back then that some of this biofilm or some of this plaque that develops even supragingival can be very complex microbial plaque that is developing that we don't recognize. And by 1968, we actually learned that gingivitis can be a very pathological condition, even though we recognize some patients do not progress to periodontitis, some do, and we've never been able to recognize who will and who won't. Well, today we can. And the reason for that even begins back here by stating that this pathology is not recognized by the typical hygienist, dentist, or periodontist because it's disregarded. We haven't been able to actually measure who's at risk for periodontitis before salivary diagnostics. So again, as we look at the dilemma that we had, now we have a solution. What is the solution to diagnosis? Well, the solution is that our diagnosis has to be based on causation or etiology and pathogenesis of the disease. Well, which ones are those? Well, we know today, based on a long-term study looking at 60 years of oral microbiology studies, just published last year in the Journal of Medical Microbiology, that only 5 microorganisms are the ones we need to be concerned about. And I'll talk more about that as we progress. But we must base our treatment planning on the exact infection of each individual that we are treating. And the other thing is that our treatment goals, here's one here relative to chronic periodontitis, published by Microbiome. It relies heavily on the elimination or at least control of known pathogenic consortia that are associated with the disease. Well, guess which ones they are? They are the red complex bacteria, or also called keystone bacteria that we made reference to. Well, what about aggressive periodontal disease, Tom? Is it similar or is it very different? Well, when we look at this study, it simply says that in conclusion, there is a similar prevalence of red complex bacteria between general aggressive periodontitis and general chronic periodontitis patients. But their count was higher. What does that mean? Their concentration, the numbers of these microorganisms grow over time. But in both types, whether it be chronic or aggressive, the red complex as a whole, not a single bacteria, but the red complex as a whole should be considered as a target in both the prevention and treatment of generalized periodontitis. Note that prevention, we can prevent periodontitis if we know red complex is there. We'll talk a little bit more about biofilm maturation, because that concept itself told us originally the only red complex bacteria were late colonizers and you could only find them in deep pockets. That's totally untrue today. Red complex bacteria are found in supragingival plaque biofilms as well, and are found in pockets less than 3 millimeters. So we need to recognize we can prevent disease, we can treat it more effectively with testing for these organisms. Okay, Tom, I get it. So we have to have these microorganisms. How do we locate them? How do we find them? Well, here's a study 20 years ago. Microbiological analysis and antimicrobial therapy should form the basis for diagnosis and treatment. That's pretty simple. And it's 20 years old. And the oral microbiologists of the world have been proposing this for decades. However, we've been taught, and our practitioners have been taught and have traditionally chosen treatment based on personal bias rather than data from microbiological studies and rigorous clinical trials. So what do we really need to know about scaling and root planing without any adjunct therapy at all is that it's beyond the power of mechanical therapy alone to eradicate these pathogens. Therefore, we have to see these patients every 3 months. Even though bleeding has not totally been dismissed, we say that we've come to the endpoint of therapy because we've reduced bleeding or we've reduced pocket depths. And yet we clearly see that some of these patients are not as healthy as we'd like for them to be. So there's two most important concepts that have changed as I'm kind of introducing this model here. Is number one, and this was a very interesting article called Understanding the Microbial Components of Periodontal Disease and Periodontal Treatment-Induced Microbiological Shifts. Again, I made reference to it early from the Journal of Medical Microbiology just last year. So what do we need to know? We need to understand, first of all, that the microbial components of each individual is slightly different or maybe severely different than the patient that you just saw. Even though the clinical presentation may look similar or exactly alike, the infection may be very different, because periodontal disease is a multimicrobial inflammatory disease that causes systemic inflammation, and specific pathogenic species causes this dysbiotic state. And yet it varies from person to person based on not only their presence, but also on their concentrations. And I put a little note here, it didn't come from the study. I put a little note here, and that is, quote, risk factors do not cause disease. Of course, they are involved in the progression of disease, severity, and so forth, but they are not causative. The second thing we need to recognize is, what is our treatment doing? And this, again, reiterates the other statements that I made earlier. So how does our treatment induce microbiological shifts? Does it? In other words, we have to, some way or another, revert back to a stable microbiota or a stable group of organisms that are responsible for health. Well, scaling and root planing or non-surgical therapy just using scaling and root planing doesn't do it. So we must adopt, as this article has clearly stated, targeted treatment based upon the saliva test before and after treatment. Get that, man. We must adopt targeted treatment. There's no way we can target treatment by using a probe, staging or grading, looking at bleeding, looking at attachment loss, and looking at everything that we've done, which are good things to do. Don't get me wrong. I'm not saying we shouldn't do that. But what I am saying is we have to adopt targeted treatment and use tests before and after to determine if we've achieved result. So what is our first goal in periodontal treatment? Yes, of course, we want to stop bleeding, we want to reduce pockets, and we want to save teeth. That's a norm that for all of us. But here's something new. Periodontal therapy that abrogates systemic inflammation. Well, goodness gracious, how in the world are we going to know if that's happening or not? Well, the one thing that we can do relative to that is eliminate those pathogens that cause systemic inflammation. If we've done that, then we know we're on the right track to making sure the mouth is not a source of systemic inflammation as a source for many chronic systemic diseases. Only way we can know that is to test. The second goal here and from this study is to promote a shift from predominantly pathogenic microorganisms to a host compatible one. Very interesting too, the study showed that when we eliminate these keystone pathogens or high-risk pathogens, that the healthy microflora grows much faster and is much more abundant. And so it replaces these bad bacteria in a very rapid session. And if we can keep it there, then we know that we will have a healthy mouth for long periods of time. And then again, the only way we can know that is to test. And then the last goal was from a clinical trial from Colombo in 2012. And their group, this was a well-controlled clinical trial relative to looking at how well we're doing with periodontal treatment, scaling and root planing, plus periodontal surgery. So they looked at these individuals that were, the treatment was performed by well-trained periodontists. And they did the scaling and root planing, and then they did surgery on every pocket that was greater than 6 millimeters. And then they looked at them 15 months later. Well, guess what? Just using scaling and root planing, no adjunct, periodontal surgery, no adjunct, 35% failure rate. What does that mean? That 35% of those that they treated had advanced disease after just 15 months. So what did they say? What was the conclusion? See, they were testing microbiologically the same microorganisms that you're going to be able to test for. All failure was due to microbiologic instability. What does that mean? That simply means the microorganisms were not removed in the beginning and that it came back in full force at the end. So the ability for us then to actually change that perception is a real reason for us that we have to test. And get this, all therapy options will have to be validated by these parameters. What does that mean? Well, that means that if you're using trays, you have to validate before and after. It means if you are using local antimicrobials, you have to validate. If you're using lasers, you have to validate. If you're using ozone, you have to validate. It doesn't matter. I'm not trying to change all of your protocol. I'm just simply saying you need to measure whether your protocol is working or not. You need to target pathogens, and you need to make sure that your treatment is eliminating the pathogens, or at least reducing them to a level that is host acceptable by the individual that you're treating. So we want clinical stability. We know how to measure that. We've been doing that for 100 years, but we don't know how to measure microbiologic stability. Some would say, well, Tom, there are 770 different species in the mouth and billions of microorganisms in the mouth. How do we know which ones are bad, which ones are good? Well, you don't need to go through the clinical trials. That's already been done. Journal of Clinical Microbiology, just published last year, clarifies that all we need to know are the ones that cause dysbiosis. I don't have time today really to go into the mechanisms how that does, but that we understand the mechanism how all of that transpires. And some would say, well, Tom, in a pocket, there's at least 170 species. Why aren't we treating all of those? Literature says they're all pathogenic inside the pocket, if you read the literature, and that's true. But why does that occur? It occurs because these pathogens transfer their pathogenic potential to everything there through gene transfer and through other ways of cross-talking to other microorganisms that are there. So I hope what you understand is it's not necessary to understand and measure everything that is there. It's not necessary to go to the expense, and we wouldn't understand it if it happened. So the point being is we need to simplify what all that means by having a test that's appropriate for the science. So what are we trying to do here? Well, are we trying to change everything? No, we really aren't. What I'm trying to do in this discussion is to bridge what we're doing well today with what we can do better today. In other words, Perel's pass relative to a diagnostic instrument occurred in 1936. As I stated, it cannot determine causation. It cannot determine if red complex is there. And we cannot assume it's just red complex that is there based on without a report. In other words, if you don't mind me just illustrating it this way, the periodontal probe is a lot like the Model T. They all occurred about the same time. The engineering of the Model T is very different than the engineering of a Tesla. And saliva testing is the Tesla, if I can use that illustration, of the diagnosis that we have available to it today, because it not only measures those causative agents of periodontal disease and gives us targets, but it also they are the primary source of systemic inflammation that derives from the mouth. So the only thing we really need to define is, what does saliva testing do? Well, it defines causation of inflammation, oral and systemic. It provides specific targets of therapy, and it provides a very, very effective endpoint of therapy. So I hope those of you who are listening know who Dr. Brad Bell and Dr. Amy Doneen are. When I first started the laboratory in 2008, Dr. Bell called me one day and he said, Tom, I didn't know who he was. He called me out of the blue and he said, I'm Dr. Brad Bell. And he said, I want to guarantee my work. I want to guarantee that my patients will never have a heart attack or stroke. I'm tired of this. I'm tired of general medicine seeing people have their second heart attack or their second stroke or die early because of cardiovascular disease. And he said, along with Dr. Doneen, they both said, we want to change that paradigm. We want people to live without the fear of heart attack and stroke. And so he came and visited our lab, and he's basically now will say to you, if you go to their course, and I would highly advocate and highly suggest that you find their course, the Bell-Doneen Method, Arterial Health for Life, and also Brain Health for Life now. And they basically would tell you, we can't guarantee our work without laboratory salivary test. And their primary emphasis is on these 5 microorganisms. Why? Because number one, we've talked a lot over the years and they understand what I know, and I've talked with them a lot and I understand what they know. In fact, I am now a patient of them, and I have been for the past 11 years. So I do not fear heart attacks. I do not fear stroke. I do not fear diabetes. I do not fear dementia. I do not fear Alzheimer's disease, because I'll never have any of those. But why? Because they have helped me understand where I need to be, and the testing that they do gives me an insight as to where I am every time, every 3 months that I have my blood and urine test done, and my saliva test as well. So here we are back a number of years ago when we were lecturing together, and I've been privileged to lecture with them for a number of years. So I highly would suggest anyone that's not been to their method, and I have no financial reason to say this, please look up the Bell-Doneen Method. So let's talk about healing disease. I sometimes begin a presentation by saying, do you believe that we can cure periodontal disease? And most of us that have been taught through our traditional training are somewhat shocked because they think it's a trick question, but it's not a trick question. It's just a real question. And that is, can saliva testing change what we do? See, that's a question that is often asked to me. In fact, when I first presented our discoveries, our test at the International Academy of Periodontology I think it was in Spokane. No, it wasn't in Spokane. I think it maybe was in, I can't remember exactly where it was. Anyway, when I presented our first test, one of the listeners at the end of the meeting stood up and said, asked the question and said, why do I need to test? I can see periodontal disease. It's totally shocked me, because that's where we've been taught. So we're waiting for disease. We're treating disease late. The literature clearly says that. It's like saying, I'm going to wait until you have a heart attack, then I can say, yes, you've had a heart attack, and now we're going to help save your life. We're going to do heart surgery, or we're going to do this, that, or the other. And that's kind of what we're doing today with periodontal disease. We're waiting for disease to happen. And then we're saying, oh, you've got disease. And there are many reasons for that. I think one reason is that's the way we've been trained. And number two, the Periodontal Probe can't answer that. And number three, insurance companies. See, the insurance companies are demanding that we can't treat it unless we can actually see loss of bone in the human skull. See, the maxillary process is directly connected to the rest of the skull. The mandibular process is indirectly connected to the human skull through the mechanisms of the temporomandibular joint and the muscles that keep it there. But look how close it is to the brain. It's part of the skull. And we are asking our patients to wait until your skull is infected before we treat. That doesn't even sound like modern medicine to me. It's just blows my mind that that's where we are, basically relative to this conversation of can we heal disease? We have to heal disease. In order to do that, it's like saying to a patient that has cancer that let's wait till you have stage 4, and then we'll start getting concerned. But wouldn't it be a lot better to, let's say, diagnose early and prevent it, or number 1, catch it in stage 1? That way we can reverse it and cure it. Or diabetic patient, we know that we can prevent diabetes, but do we wait till a person has type 2 diabetes before we say, okay, you have type 2 diabetes, now we're going to have to treat it? No, there are things that we can do to totally prevent diabetes. Same thing is true periodontal disease. We can totally prevent it in all of our patients. Of course, many of our patients have it before they get to see us. But the point being is we have to think differently. And I use that term. It's one of my favorite terms from Albert Einstein when he said we don't have to think more. We just have to think differently. But I would suggest to Dr. Einstein, for us, we do have to think more because we have to reverse what we've been taught. And we do have to think differently about periodontal disease. It's a serious chronic inflammatory disease. My concern about periodontal disease is that it's taken a back seat to so much that we're doing wonderful things we're doing in dentistry today. See, I don't even think dentistry is dentistry anymore. I think it's oral medicine. I think the things that you are doing in your practices in changing smiles and placing implants, looking for oral cancer, looking for periodontal disease, all about medicine. It's really not just about teeth. So that's the reason I want you to think about yourself differently as a healthcare provider, not a tooth cleaner, not a tooth fixer, but everything that you do that you tie into the potential difference that you might be making and that you are making in the systemic health of every person that you see. You have the ability to keep people alive longer and alive healthier. So it's very important that you revisit this topic of periodontal prophies, or this topic of prophies versus periodontal disease. If 80% of the population has some kind of bleeding, then there's something wrong with that picture. And if any patient in our practice continues to have bleeding, there's something wrong with what we're doing. So the questions are, can saliva testing change what we do? And the answer is yes. That was another question that I had at the international meeting, and that is, how does testing change what we do? Well, I'll show 2 or 3 little cases here today. I have many, but I don't have time for that. And then the last question is maybe the most important. Well, those both are very important. Can it change outcomes? And I want to show you that it can change outcomes. In my practice, for 36 years, I spent 2 years in the Navy and rotated through oral surgery and also through periodontology. But I practiced in a small town, serving those who needed surgery, those who need periodontal treatment, because we didn't have specialists. So my background is a little bit unique because small town primary care providers have to do things that when there are no specialists around. And so one thing that I saw in my practice for many years were patients that had been treated before. And they would come in and we would do an examination, and I would ask a question, something like, well, how long have you had this infection? And they'd say, what infection? And I'd say, the periodontal infection or the gum infection. Oh, I don't have an infection. I've been treated for that. Well, what kind of treatment did you have? I had deep cleaning. How many times you've had that happen? Oh, we do that every time I go in to see my previous dentist. Well, this is an interesting story here. It's not my case, and I'm not going to show any of my cases because I want people to show their own cases, and I want you to show how we document cases. This is what we train our hygienists and our dentists and our hygiene assistants and our dental assistants and our front office, all the people in our practice. We want them to understand not only the serious nature of periodontal disease, but also how to document cases in such a way that you can create your own presentation to your own patients or to your own community. We can help you do that. So here's a typical case that I saw in my practice, although this is not my practice. This is a individual that was in my son's practice, and this individual had previous periodontal treatment 3 different times. And hold on for just one moment here, please.
Sure, Tom.
I apologize for that. Little puppy here visiting and was a little loud. Excuse me for that.
Well, it's a
So
very
this is
compelling presentation, so I
I'm
understand his
sorry?
interest. I said it's
I'm
a very
sorry.
compelling presentation, so I understand his interest.
Well, thank you very much. I do apologize. So here's a typical patient that has been treated 3 different times. She's in her early 30s. Twice she was treated by an office with in a general practice in the traditional model. But you know, you look at this and you say, gosh, she doesn't need a lot of scaling and root planning, and right, really she doesn't. Her hygiene is really excellent, except you see all this redness in the front there and around. The last time she went to periodontist. The periodontist did the same thing general dentist did, and then finally said, threw his or hands up. I'm not accusing anybody. I'm just saying that 3 different offices attempted to resolve this problem. The final solution was by the periodontist is said, well, we just can't cure this. So I think we're just going to have to remove this infected tissue and then do some type of graft here with some healthy tissue and hope that this heals. Well, she wasn't real happy with that, and she visited my son's practice, who had been using DNA testing now probably longer than anybody in the country other than myself. And so he said, well, gosh, you know, let's go do a perio exam. Let's look at your history and let's see what has been done. And this has been going on now for approximately 10 years. And I'm not going to go through everything that was done, but it's really a pretty simple case. So first thing was a test. And if you look at the pictures, you can see the big picture of the initial retracted. And then on the second side, you see a close-up. You say, wow, this is really angry looking. It was uncomfortable. And so if you look at this lower test, those of you who have used the oral DNA test, this was the first test that I brought to market. You can see there's high-risk pathogens on the left side, moderate-risk pathogens in the middle, and low-risk pathogens. The reason that was listed that way is because of the data that we had back in 2006 and relative to understanding causation. We knew high-risk pathogens caused alveolar bone loss. We weren't sure about moderate, less sure about low risk, but we included them all. And so what we've done here is we now have discovered something that is creating the story here. And that's the long purple line. That for the scientific name is Aggregatibacter actinomycin comides, but we typically call it AA because nobody wants to say that. So we've got AA presence in large volume, and we have a little TF and a little bit of TD. But in this original model, we wanted to target the most pathogenic organism at the highest concentration. So the target organism here is AA. So we're going to do some very mild deplaquing here. We're going to, in this particular case, I'll just tell you how they did it and kind of the way that we created a model from Dr. Jürgen Slotz at USC. Using chlorhexidine in the irrigator and then putting her on chlorhexidine at home in an irrigator for 2 weeks. And in this particular case, because of the time that was involved and because of the difficulty here, she was placed on the appropriate systemic antibiotic. And I know I'm just going to address this to say, yes, I know that there is a lot of discussion about the inappropriate use of antibiotics. This is a very appropriate use. I know there's risk. That's a conversation all of us have to have with ourselves and with our patients. There's risk here. We understand that. I will tell you, though, that if there's another way to treat this case without antibiotics, we're all for it. So we're not a laboratory that pushes antibiotics. I want everybody to know that. But in 2008, this is the way we were treating these types of patients, and it worked very, very well. Now I'm going to show you two. These are our targets of therapy. Hope everybody understands that. And I'm going to say we don't even need the rest of them anymore because the literature today in 2022 has advanced. So I asked this question, and I'm going to block out everything else because I'm not even worried about them anymore. Is it possible that if we target AA, the purple line, that this patient will heal? So along with the scaling and root plan, we can use an antimicrobial that will kill AA. It's that simple. And so we're going to use local medications, and in this particular case, a systemic antibiotic for a short duration. And then we're going to retest her and relook at her. Here's her x-rays. Of course, she has some bone loss, obviously, and here she is 3 months later, post-treatment. I show this case just as an example. We have many cases that show how this works. Not only do I want you to look at the front surface here but look at the entire mouth, how it looks different than it looked back here. See, you wouldn't have thought that this mouth was infected until you saw this. Look how the tissues have responded to the removal of AA. We didn't totally remove TF, but look what happened to the moderate risk pathogens. And I'm going to show you those in comparison. The reason they aren't important is because when we target high risk pathogens, it also resolves the other issues. And here's an example of that. Here's our first and second test. And this was done approximately 1 month apart. No, was it? Yeah, 3 months apart, relative to looking at the clinical presentation that we would call, I think we would all call that clinical stability. There's no bleeding. Here we also have clinical stability, microbiological stability. Why? Because it matches this. So when we removed AA, look what happened to all of the other red except for TF, and look what happened to all of the orange and the green. We're not trying to sterilize the mouth. Yes, the most of these on the right-hand side in the middle are normal bacteria that become pathogenic because of the presence of red complex. But when we get rid of the red complex, or at least reduce them significantly, then the numbers of the others tend to go down as well. So I just wanted to point that out. So don't be concerned about the moderate. So here she is 1 year later with just routine home care. Here she is 3 years later. Here she is 4 years later. What I want to show you here is this is totally different from what the literature will say. The literature will say, and it's right, and that is if you are only using scaling and root planing, these pathogens will return in 3 to 7 days. But if you eliminate them, see, the literature is also saying that the normal black flora will return to a level that the others cannot regrow unless there's a source of reinfection. Now, there can be a source of reinfection. Maybe it's an unerupted third molar where the infection actually returns, or maybe it's a deep pocket, a 6 millimeter pocket. I will just say, too, to our periodontist colleagues, that we do need to work together better, because if there's a 6 or 7 millimeter pocket, I would highly recommend that we reduce that in some way, either some grafting or whatever we need to do to reduce all of these spaces that might create a reinfection. The point is here that yes, we need to collaborate with our specialists of all kinds in the medical community and our community as well. So here's a 4-year resolution. Here's the third test on the right side. Even after 4 years, look how stable her microorganisms are relative to what we started with. We started here and we ended here 4 years later with no additional aggressive treatment, with just normal routine every 3 months, basically, for her, polish, because I mean she has excellent home care. So I guess what I'm trying to say here is yes, it's possible to cure infections. Now some we can't, I agree with that, no doubt about that. So what have we done here? What have we actually done when creating a microbiologically stable patient and also achieving an endpoint of active therapy based on a test result? Well, we have done a number of things. What we've accomplished: one, we've healed her infection. There's no doubt about that. Can she be reinfected? Of course. If she gets, let's say, married, I don't know what her history is, then the husband has severe periodontitis, she will be infected. If somehow she stops doing what she's doing, it's possible for her to be. If she becomes pregnant, I don't know exactly. You know what I'm saying? If things change in her life, of course she could become reinfected, but she's not now. The point is, yes, we've healed her infection. Secondly, we've stopped this infection as a source of systemic inflammation. So here's another case, very severe case, a patient that came into, again, my son's practice. This was a different hygienist in his practice, but they all used the same model. The test that you see on the right is from Hein Diagnostics. This was the first test I brought into the U.S., and it's actually a test out of Germany. We didn't have a U.S.-based lab, and I was sending samples to Germany, so my son was too, and this was the test result. It looks different, but it's the same organisms that we developed in 2008. And if you look at the initial picture of the person, you can see there's a draining fistula. If you were to look at the x-rays, you would see this is an 8 to 12 millimeter pocket. I don't know exactly how deep it is. Nobody does, because periodontal probes are quite inaccurate depending on who's pressing the probe in this site. It was a draining pus. I would just say to you, I have no fear at all about recommending an antibiotic when there's pus. Why do I say that? Is because there have been more than one legal cases against dentists and periodontists for treating periodontal disease where there's pus without an antibiotic, and patients ending up with brain abscesses, and the provider, in other words, the dentist or the periodontist, have been found guilty of malpractice by not using an antibiotic. So there's a two-way street here relative to this conversation of use antibiotics or not use antibiotics. And these cases have all been reported and some published in the ADA. They are now recognized by an entire legal consortium that is now looking at periodontal disease as a potential huge lawsuit area when dentists and periodontists are not appropriately treating infections. So I do think that we need both sides of this conversation with our patients and with our physicians and with our patients to determine what is the least damage we can do to the microflora of the mouth, and yet what is the most effort that we can make to cure these infections. So it was a tooth here that needed to be saved because she wanted to wear braces. She wanted to get her spaces closed. We know she's going to need some restorative work after that. So it was really important that we saved that tooth, or they saved that tooth. So here's the test. She was infected with no AA, but she was highly infected with PG, TF, and TD. Notice the difference. The other patient had AA, didn't have PG. And then TF and TD are much higher based on numbers. Don't worry about the lines and colors and all of that. Just know that she's highly infected, as we would expect. But look at her, and this is about, I'm thinking probably 12 to 14 months post-treatment. Look at the difference in color of the entire mouth, and no surgery was done here. We were ready, or we would have been ready if she were in my practice. So I'm sure she would have been ready for some periodontal surgery if necessary. But first of all, even before surgery, we would have wanted to cure the infection or at least get it under control. But look at the color and look at the stability, both clinical and microbiological. See, this is the best we can do based on using, let's say, a clinical laboratory report before and after, and looking at clinical presentation. Of course, we're going to look at systemic diseases. We're going to look at staging and grade. We're going to look at all of the things that you are doing, but to add this one simple thing resolves so many problems and helps so many people in different ways. Well, is saliva testing critical relative to the topic of oral systemic? And is the oral systemic real? Well, it is real. And this was a publication, February 2021. The point that we want to make here is that periodontal disease and the systemic inflammation that is caused by periodontal disease is not just a consequence of risk factors, but is driven by multiple microorganism-induced immunological mechanisms. This fact is clear that these microorganisms drive systemic inflammation, and these organisms that you're looking at are the ones that are most important. So it is very importantly that we recognize the literature today, and this is in Nature's Review of Immunology that is read by every medical group in the world. Clinical trials, epidemiological, clinical, interventional, and experimental studies clearly show that periodontitis impacts systemic health through understandable mechanisms. I don't have time to show you the mechanisms here tonight, but we understand that. And targeted therapies against specific pathogens might eliminate or ameliorate specific comorbidities. We know that it does because we are now working with physicians, nurse practitioners, MDs, DOs, and so forth, and we're proving that through testing. Very quickly here, what we have tried to do in the past, and I'm going to run through this slide really fast because I think I have about 15 minutes left. Is that right?
Yep, that's about right.
Okay, good. So I'm going to run through this slide first. See, the problem we've had, if this was actually one of my cases that I treated and we were able to help a lot and actually resolve this infection. But we've tried to look at clinical presentation of periodontal disease in studies and compare that to the comorbidities, and that hasn't worked well. And I'm going to explain that in this way. What does the literature say relative to the diseases we should be concerned about and these pathogens? Alzheimer's, aspiration pneumonia, non-alcoholic fatty liver disease, diabetes, inflammatory bowel disease, colorectal cancer, rheumatoid arthritis, and adverse pregnancy. Well, do we understand the host responses? Yes. Endothelial dysfunction, I'll have to laugh at this one. I first mentioned the impact of these microorganisms on endothelial dysfunction about 12 years ago, and I was laughed at by some in these, let's say, dentist and dental hygiene, communities that would write back and forth. But we knew back 10 years ago that these microorganisms cause endothelial dysfunction. Everybody believes that now. But, you know, the literature is not lying to us. It does cause that. Low-grade inflammation, acute phase in the liver, metabolic alterations, the types of cells that are produced and circulate, in other words, the types of immune cells that are altered, primary osteoclastic precursors. You know, we know about osteoclast and bone loss. So how did they get there? Well, they get through the throat, and then we swallow them. They go to the large and small intestine and large intestine, cause dysbiosis through or digestive, right, through our digestive system and through the lungs. I reverse that. You understand what I'm saying? And bacteremia, they can break through the blood-brain barrier as well as through adverse pregnancy. But it's not the clinical presentation that's important. It's really these pathogens. Every literature review related to this story addresses the concept of keystone pathogens. And it doesn't really matter whether it's blood-brain or pregnancy or all of the rest of them. These are the ones that create the systemic inflammation story. And it's not just one. There are some companies, unfortunately, they are trying to address a single microorganism as the only one. They're making a mistake because it's driven by more than one. And we can validate that in many, many thousands of cases. Sometimes we talk about the relationship as a non-causal or as an association. And I'm very, very disappointed in the way the ADA and the AAP and ADHA is doing that. If you read the information in the fine print on the story of the world systemic, they are very, very meek about this story. But these studies are not. They're very strong. This is an infection and immunity that basically says P. gingivalis has been shown to cause and accelerate formation of coronary and aortic atherosclerosis. This is the main cause of heart attack and stroke, folks. This is what causes people to die early. P. gingivalis can cause and accelerate it. PG, TF, and TD induce periodontal disease and aortic atherosclerosis. Again, in 2013, what does the word induce mean? It means cause. Both periodontal disease and aortic atherosclerosis. Treponema dentacola causes atherosclerosis, infection and immunity, 2014. So it's not just an association. Yes, there are other things that cause atherosclerosis and cardiovascular disease and heart attacks and strokes and diabetes, dementia, and all of that. Yes, there are other things that cause it, but these are also causative relative to the concept of systemic inflammation and the mechanisms that are all associated with this story. And you have the ability today to test for every one of them. And you can have these conversations on a personalized basis. And when we look at Dr. Bale and Doneen and Dr. Vigorous studies that was published in 2016, relative to the story of the atherosclerotic triad, in other words, what causes atherosclerosis and this triad that causes it, periodontal disease, to these high-risk microbes must be treated effectively to reduce the risk of atherosclerotic vascular disease. What are the high risks they mentioned? AA, PG, TF, TD, and FN. And this is another reason we moved to this front. Very briefly, Nan, I'm getting close. I think I have 10 minutes. A story that ties this systemic world together. Young patient 31, she's already a type 2 diabetic, takes metformin, already hypertensive. And the story is, I'm going to go right to the bottom here, is her twin sister, her identical twin sister who lived in another state, had been hospitalized prior to open heart surgery. During that period of time, she had kidney failure and a heart valve that was malfunctioning. And so they were delaying her heart surgery because of an infection on her valve for 3 weeks while she then had kidney failure and heart valve dysfunction. And the doctor's conclusion, in other words, the vascular surgeon, the heart surgeon, concluded that her infection of her valve event started with a gum infection. And her sister was told the bacteria in her mouth got into her bloodstream and infected her heart valve, which led to the infection all over her body, and she almost died twice. So here you have a 31-year-old that almost died because of these pathogens we made reference to. So this young lady who now has seen her sister almost die says, I better find a dentist that knows what they're doing and a hygienist that knows what they're doing, because I don't want to go through that. And this is the way we document these cases. Initial retracted, FMX, she already has 6 to 7 millimeters pockets. And this is the original test, again, from Hein Diagnostics in Germany. That's no longer available to us. It was a subgingival test. And they are no longer in the US. They were bought by another company. It's not mentioned here, but this is TD and TF in the red. So again, just look at the colors. It's the red complex we're concerned about. 2-week follow-up, and here's her follow-up test. Again, their treatment, it totally eliminated TF and TD. Look at this. Can treatment do that? And the answer is yes, but scaling and root plane cannot do that. So the main points is relative to help this young lady so she'll never have kidney dysfunction or kidney failure or heart valve infection, or she'll never have periodontitis if she maintains this, and she'll never have to worry about going to the hospital because of an infected valve. So what have we done? We've eliminated her high-risk pathogens, or this office did. She will never have alveolar bone loss if she maintains this, and she has no risk for systemic inflammation that's coming from her mouth. So if you want to tie all this together, this is a perfect case for doing that. So here's a young patient that is 3 months pregnant, and she's coming in for her evaluation. So you do your probe chart, our hygienist colleagues, and you can tell there. And then all of a sudden you get this. So is this health, or is it disease, or is it just pregnancy gingivitis? Well, the probe doesn't know. A test does. So the question is, can we discover, and what kind of advice are we going to give for this young lady if it's possible that she has an infection that might cause her problems during pregnancy, or might cause a low birth weight or a preterm birth weight baby, that any of these pathogens can possibly do? We don't know. So if we call this pregnancy gingivitis, we're guessing, and we might be putting her or her young baby at risk. So can we find out? The question is yes. And this was the earliest test that we brought in. This was in 2006. And I hope you know by now, and if you can see, this early design is very different from the first one. This came also from Germany, and this is what we had back then. I helped them design this report. But by now, you should know that purple line is bad. And that purple line represents AA, which is as toxic as PG relative to the pathogenicity and its ability to cause both local disease and systemic inflammation. It can pass through the placental barrier and the blood-brain barrier just like PG can. So we're going to target AA. She does have FN, and for those that are familiar with FN, I'm not going to go into that story there, but I'm going to target, and this practice is going to target AA. I don't have time to tell all of the stories, but I want you to recognize that we can now just say definitively, yes, gingivitis during pregnancy is accelerated, no doubt about that. But also you have an infection, you have both. And so we're going to work with your OBGYN. We're going to find a way to resolve this and get rid of it. At this level, this represents 100 million of these microorganisms that are in her circulatory system 24/7. And it also represents a 7 times increased risk for pregnancy complications. And there should be interdisciplinary conversation relative to how we're going to do that. So I kind of want to conclude with 2 or 3 slides. It's about time. I think I have 5 minutes. I want to remind each one of you, from the person that works in the front to every person that works in the back, to the person that does insurance, to the person that makes financial arrangements, you're all part of a healthcare team. And each of you needs to understand why your office needs to reconsider how you diagnose and treat periodontal infections. As I said, what we're doing is what we learned, and I know you're all good at it. I know that you do that. You spend your life helping people by removing biofilm and removing plaque and calculus, and you get frustrated from time to time. I know we did, and I would just tell you, as a dentist, I actually started my practice without hygienists. And I worked for several years doing what you do, so I understand the frustration associated with this, but I also understand the need to do what Albert Einstein said, and that is we have to think differently about the serious nature of periodontal disease relative not only to our teeth and our mouth, but also to this systemic world that we all live in. Each of you is in your own way a part of a healing team. So let's reconsider where we are. Are we in 1936 where we're guessing? Are we in 2022 where we are defining disease based on a definitive medical grade diagnosis? Are we using just probe charts, or can we combine probe charts and probing and bleeding with this new world of saliva testing, now the gold standard, by targeting red complex, treating early disease, and hopefully eliminating these high-risk bacteria, helping our oral health and reducing systemic risk? It does make a world of difference, not only to our patients, but to each one of you. It's amazing when we move into this new world of realizing that we are part of a bigger team and that what we do changes lives. And we've seen that with of course, implants and with beautiful veneers. And if I were in practice today, I would want to do all of that. And I did some of that. But today it's just marvelous what we're doing. So let's create this marvelous picture of curing periodontal disease in every case that we can. And it's going to involve saliva testing for high risk, understanding disease both locally and systemic, understanding these reports, and understanding who to test. Well, traditionally, we used to think, we said, well, we're going to treat those that we failed. In other words, those are, but let's just consider this. Test all patients that have received previous periodontal treatment. Test all patients with clinical signs of inflammation, all patients with systemic disease, family members of those with periodontal infections prior to implant surgery, medical clearance prior to surgery, follow-up testing after periodontal therapy. Eventually, where many practices are today, it's become as routine as your x-rays. And I think that's where it has to be. Every patient receives a saliva test once a year to reevaluate the health of their periodontal tissues and the risk for systemic inflammation. So it's been really, really fun for me to present this. I wish I could see you. I wish I could be there, but I want to help you in any way that I can. Here's my email address, drtomnabors@gmail.com. Here's my personal cell, 615-879-3739. I'd love to talk to you. I'd love to help you achieve what you want to achieve, whatever it is in your life and in your practice. So thank you for taking your time and spending a few minutes with me and with Danny. And please let me know if I can help in any way. So good night.
All right. Well, Tom, before you go,
okay,
we've got some questions,
sure.
And that's what we tried to save time for. So
yes,
I hope your puppy can wait a few more minutes.
Yeah, I hope
for
so
the
too.
attention that he clearly craved.
Yes,
but that was another tremendous presentation. I know your knowledge and your passion are what's self-evident. And
thank you.
As somebody who's seen you delivered these presentations in person, I can tell people, and they may not really believe it, but it's even more fun to have you there in the flesh. But let's dive into some questions here while we still have time. One question I've got for you is just along the lines of early intervention diagnosis. Why not test all patients, whether they present with some symptoms or not? Why don't we try to catch it early?
That's exactly what I ended with, and that's where we're going. I was introduced just 2 nights ago to oral maxillofacial surgeon, who another presenter was talking about saliva testing, who now test their patients and are starting to test all their patients. And this individual is both a doctor of medicine, a doctor of dental medicine as well. And after the other presentation showing some of our cases and talking about saliva testing, that's exactly what he said. He said, if I were in a private practice today in general dentistry, I would be testing every patient once a year at least. That's where we have to go with this, Dan.
Right. Well, because I got tested a couple of months ago, and I'd been tested by oral DNA labs twice in the past 10 years or whatever. And I had no symptoms, but I wanted the peace of mind in knowing what was and what critters were inhabiting my system and what weren't. And it was really great to see there was no detected AA, no PG.
There you go.
And that the TDTF and FN were all at acceptable levels. So
love that. Yeah. That's a great story. I appreciate that.
Yeah. All right. Next question. How many dentists nationwide are already using saliva testing, and is the trend increasing?
Well, that's a great question, and I'm sorry I can't totally answer that. When I started oral DNA, well, let me go back. When I started with what we call advanced dental diagnostics in 2003, from 2003 to 2006, we probably introduced saliva testing and those that were testing to something like 10,000. So practices during that period of time. And I'm giving you, let's say, a raw estimate, but just based on those 4 to 5 years there. In 2008, again, we made a much more aggressive entrance into the market with oral DNA, and oral DNA is still going strong, and it's I think 14 years now since we started oral DNA, and they have the numbers of that. But let me just say this: when I started oral DNA, and we were purchased by Quest Diagnostics, the second largest clinical laboratory in the world, in 2009, and then I served as the chief dental officer on Quest, but I was still there at oral DNA, and by that time I'm estimating we I don't know, by that time we had several 100,000 tests, and so I don't know how many practices were there. I guess I'm kind of beating around the bush to say I don't know. I know that we have thousands, but I don't know what the I don't know what the answer is. It increasing? Absolutely, it's increasing.
Yeah, it would be nice if we could get a little bit of upward pressure on the practitioners from their patients to just be aware of this. So maybe a PR campaign is indicated.
Absolutely, it would.
Yep. Do you assist with the interpretation, like for new users? Do you have a program that assists with the interpretation of the results?
Oh, I love that question, because what we learned in the very beginning is that the test is one thing, interpreting the test is the other thing, and that it does require a short period of just learning. What does it mean? How to tie it together. And if a person asks a hard question, can you document that? And so in our new lab, the one thing that we did very different is we have an entire educational program, and that's designed just for that. And in the educational program, number one, it's not designed to totally change everything that you're doing. So I don't want any marketing person in another company or any company to think, well, gosh, we're trying to tell people to do it our way. We aren't. We're just trying to say test before and test after. If you get good results, your program's working. If it's not ideal results, we can help you. So the answer is absolutely. We'll help you with every case until you get comfortable with it. So if you decide to work with us, then contact me. I can put you in contact with the right person.
And I guess this is a related question. To what extent do you advise that we consult our patients around the specifics of oral pathogens and systemic disease, or simply perform the test and share the results and the treatment?
Well, for me, when I was, again, in practice, and as we all know, we attend CME courses and we are required, but also there are a lot of courses we go to because we're not required because we want to. But I would just say that new courses always created enthusiasm for me. I wanted to share that information with my patient. When it came to testing, and my first test was phase-contrast microscopy back in 1983, and I couldn't wait to tell patients that we were going to test them with a microscope. Just the excitement that I had um, was enough to help people realize how important it was to me. And if it's important to me, it becomes important to them. So I would suggest to you that the concept of, let's say, number one, you want to adopt testing is not one where you create from memory a language or a sentence structure that says that it comes up from your heart. It becomes from your desire to help that person. And I can't wait. This is the kind of conversation I can't wait to say, Ms. Jones, we now know an answer that we haven't had an answer before. And we know how to help you in ways we never had before. And we're going to use a saliva test to get that information. Is that okay with you?
Yeah, and I have to say too that the report is very user friendly, patient friendly.
Yes,
It's
it
2
is
pages.
Yes.
And you've done. I mean, it's even simpler than the oral DNA, and it's far simpler than the Heinen report, if that's what it was called. Which I laugh at how militaristic almost it looked. They look like missiles or something. Leave it to the Germans, but I don't want to get in trouble here. But
they were they started it, so that was good.
Yeah. Okay. Well, we finished it.
Any other questions?
Never mind. Now, let's just confirm your distinction, because you use the word cause and induce in different set, but then you mentioned they mean the same thing. You mean you mean when you say induce and cause, you mean
that's
they're
correct.
synonymous.
Yes, that's correct. Yes.
Good. You seem to at various points classify FN as moderate or high risk. Is it one of the holy of the keystones?
Okay. Yes, it is a holy keystone. And the reason it is because of the studies relative to one, we have one clinical case study of a fetal death, a full term fetal death in a young lady that was within days from delivery. They couldn't find a heartbeat. They induced, the baby was not living at the time of birth, couldn't revive the baby. They analyzed the amniotic fluid. The amniotic fluid was infected with Fusobacterium nucleatum. Then they analyzed the saliva, and the saliva was the same based on genetic variations, the exact same Fusobacterium nucleatum that was found in the amniotic fluid. The amniotic fluid is infected, the baby became infected and died as a result of the infection. So we know that Fusobacterium nucleatum specific genetic variations are very toxic. And there are numbers of genetic variations of FN. And I don't want to get too deep in this to confuse people, but I do want you to know there's crosstalk between, let's say, PG and FN. FN is a commensal. It's a normal bacteria, typically harmless and very protective. And you're going to see a lot of them in healthy individuals. But in the presence of PG, as an example, due to the ability of PG to transfer the pathogenic properties of itself into FN, FN becomes pathogenic. And I hope everybody understands what I'm saying. That's called gene transfer. And that's what's so scary about these high-risk pathogens, is they have the ability to do this to any microorganism that is in close contact. And therefore, non-pathogens, even in the orange complex and in the green complex, become pathogenic as long as they are in that influence. I kind of tie it into, one time somebody asked me, kind of like a gang, you live in a neighborhood and you're a good little guy and you want to be a good guy, and then all of a sudden a gang member comes by and he threatens to beat you up. You say, I'm going to join the gang to keep from getting beaten up. And next thing you know, I'm doing the same thing they are.
You're weaponized.
Yeah.
Yes.
So the gang weaponized me. So I love that term. PG weaponizes everything it comes in contact with.
Yeah, very interesting.
Yep.
What is the AAP's position on the use of saliva testing?
Well, the AA position and the ADA are very similar, and they recognize the importance of salivary testing, but they do so, and they actually have promoted salivary testing really for the past 12 years, 2010, great articles by the ADA recognizing that. And but here's the thing that is so important to all of us as healthcare providers, and that is we have to know the science. We can't depend on any organization to tell us everything about every science. And so we have to realize that the story around the dysbiosis from the mouth is a 140-year-old story, meaning that we have had microbiologists and immunologists look at this story for decades. And they didn't have the technology. The first thing was the microscope, but when Dr. Lewis invented polymerase chain reaction so that we could decipher genetic sequences, that changed the whole world of medicine in general and infectious diseases. And it changed our world too, because it gives us the ability now to look at different microorganisms and determine the pathogenic properties, and also look at clinical trials that relate to that. So the final answer is yes. Does the ADA and AAP come out and say, we want you to use direct diagnostics or oral DNA or whoever the rest of them are? No, it does not. And there will be different clinicians that either know or don't know, and most of them have never used. So if you ask someone, as an example, some people will ask me, well, do we have periodontists use it? Yes, we do. But those are the periodontists that recognize the significance of it. Do we have some periodontists that would tell you, no, I don't use it? Of course we have. Why? Because they haven't really studied it. I know we think that all of our specialists know everything, but guess what? They don't. And I don't know everything about implants, and I don't know everything about restorative dentistry. So the point I'm saying is, think for yourself, and also think for your patient that this is a helpful thing for you and your patients.
Right, and learn for yourself. Don't wait for the organizations that are no. I mean, they are by definition very conservative and somewhat bureaucratic too.
That's exactly right.
If you want to be in the lead, the leading edge on this sort of thing, then
let me just say this too, Dr. Dale and Dr. Bale and Dr. Doneen. If you look at their work, the American Heart Association will say, yeah, that's good, but we're not going to recommend it.
Right, exactly.
You see what I'm saying? So
yes, sir.
I want to follow guidelines that waits for me to have a heart attack and then tells me that I have a heart attack, or do I want to prevent a heart attack?
Yes, and have someone that has the confidence in their modalities to guarantee that I won't.
Absolutely. So Brad and Amy
is pretty impressive.
Absolutely. Yes. Brad and Amy are doing all kinds of tests for me that my internist or my cardiologist are not doing, but they are approved tests that are validated to be helpful by the science. So who am I going to go to as a person that wants to live longer and live stronger? I want to go to the one that prevents disease.
That's right. That's me too. Well, I've got time for one more question, and then we'll make some concluding remarks. So when you state the need to validate and measure, how soon after treatment should one be tested? And just by way of example, I was asked to wait 30 days until after I had my prophy to be tested.
Yeah, I love that, 30 days. And the reason for that is this. When we look at biofilm maturation, by the way, there's no perfect answer to this. The literature does not have a clear, and also individuals, obviously, once they leave your practice, are going to do things very differently. You hear what I'm saying? There's no perfect answer here. So you have to customize that to the patient per se.
And
there were some patients that I wanted to see at day 8, those that I was putting on systemic antibiotics because I wanted to make sure they finished the antibiotic, and I wanted to make sure they finished the chlorhexidine, and I wanted to test them on day 8 because I wanted to make sure everything was working. But I didn't do that for everybody. But the latest that I wanted to go out was 30 days. They were patients that I was comfortable with that were going to follow the instructions and they were going to use the rinses and irrigators. We always used irrigators and antimicrobial rinses and so forth. There are other models there that I didn't have available to. So again, I'm not trying to tell you what to do, but I think 30 days is as far out as I would want to go for a good patient. In other words, a compliant patient. Why? Because of a biofilm maturation. It begins to mature within hours, And if they are doing a good job of controlling the maturation process using the model that you've, in other words, it's not just toothbrushing and it's not just brushing and flossing, folks. You have to, in other words, when you finish treatment, you're going into healing. It hasn't healed yet. And sometimes these patients don't heal for 3 to 6 to 12 months, depending on how much bone has to regrow. And so I think 30 days without going into great deliberation is as long as you want to go.
Excellent. All right. Well, thank you very much for that. And now
Yes.
I invite you all to mark your calendars for Thursday, August 25th, when our special guest presenter will be dental and oncology specialist Sarah Jane Snyder, whose presentation is titled Photobiomodulation Therapy for the Dental Professional, Shining New Light on Practice Profitability. There is a large body of published clinical evidence for the effects of PBMT, previously known as low-level laser therapy, on musculoskeletal pain. There is growing evidence that PBMT works well on a range of oral pathologies and is beneficial for orthodontic procedures and oral facial pain syndromes. PBMT can also reduce the use of anesthesia for children and be used to reduce the local discomfort of injections. Sarah Jane is a dental oncology specialist expanding the use of PBMT in dental practices and oncology centers for the benefit of both patients and providers. Reviews published by The Lancet, BMJ, and the International Association for the Study of Pain show that PBMT improves the speed and quality of tissue repair, reduces inflammation, and has an analgesic action. As an attendee, you will learn what PBMT is and how practices benefit from its use, specific mechanisms of action, and how PBMT benefits your patients and the community. It all happens on August 25th, so please be sure to save the date and watch your inbox to register. Until then, this is Danny Bobrow thanking you for your commitment to practice perfection, and once again thanking Dr. Tom Nabors for his time and attention. Goodbye, everybody.
Thank you, Dan.